So the next set of disorders that we're going to be discussing that affect renal function include the inflammatory disorders. So these inflammatory disorders um, can be classified as glomerular nephritis. So the glomerular nephritis is really broken down into two syndromes, and really these two syndromes are going to differ in their causes. They are going to impact the renal function pretty similarly. So glomerular nephritis is going to be inflammation of the glomerulus, and so just like in any inflammatory event, the initial response to this inflammation event is going to be an increase in permeability. Prolonged, it is going to reduce and impaired renal function. So oftentimes, glomerular nephritis results following streptococcus infection or an autoimmune disorder. So risk factors for developing this glomerular nephritis include immunodeficiency after you have combated an infection and now your immune system is depressed. Any kind of chronic inflammatory event, meaning autoimmune disorder like lupus, rheumatoid arthritis type 1, diabetes, chronic type B hepatitis, or gender, right? So your gender impacts how at risk you are, and males seem to be more at risk than females. So what we see here is that renal function is going to be impaired in all glomerular nephritis, but it may take the form of multiple types, either nephrotic syndrome or nephritic syndrome, which we will discuss the differences between those two conditions. So nephrotic syndrome is going to really be initiated by autoimmune disorders primarily. And so this is going to be due to antigen-antibody complexes lodging in the glomerular capillaries, activating the immune complement system. And remember that the complement system activates an inflammatory response, which can increase the porosity of the capillaries, resulting in higher filtration. Now, in this nephrotic syndrome, we actually get thickening of the basal membrane, which can reduce glomerular filtration in the end. And so really this condition is defined by the presence of protein in the urine. Okay, so that's what really sets this apart from nephritic syndrome. Nephritic syndrome is going to be defined as the presence of white blood cells, red blood cells, and maybe even proteins and lipiduria, and we'll talk about those conditions in a second. Okay. So what causes this nephrotic syndrome? We could get chronic inflammatory events like systemic lupus erythematosus, maybe type 1 diabetes or hepatitis type B, or we could get infections also causing it. Infections like streptococcus infection or mononucleosis, or a response to drug therapy like non-steroidal anti-inflammatory drugs. So the manifestations that we see in this nephrotic syndrome include an increase in glomerular capillary permeability, leading to proteinuria. So this proteinuria is the definition, really the defining characteristic that we see in this nephrotic syndrome. We also see lipiduria due to increased liver function, and so the liver function is going to increase lipid production. We would expect to see hypoalbuminemia, and hypoalbuminemia is talking about decreased albumin protein in circulation. Okay, so then that refers back to the proteinuria. So the protein in the urine is probably going to be albumin and maybe even antibodies. Okay. And so this proteinuria results in a decrease in colloid osmotic pressure. And so if you decrease colloid osmotic pressure, they can result in systemic edema, or really edema everywhere. And so because remember that coiled osmotic pressure was responsible for reabsorption and capillary exchange, and if you have a decrease in proteins, now all of a sudden your coiled osmotic pressure has reduced substantially, and now that fluid that is in your interstitial space can't get back into your circulation. So now we have nephritic syndrome, which is going to differ. It's very similar. We get inflammation of the glomerular capillaries, really the result of antigen antibody complexes present. And again, this antigen antibody complex can be due to an infection primarily. So we see the streptococcus infections and viral infections are causes of nephritic syndrome. And really, the defining characteristic here is that we get glomerular filtration occurring 10 to 14 days after the infection has subsided, and then autoimmune disorders can also cause this. So nephrotic syndrome and nephritic syndrome are very, very similar, but they are going to differ in the manifestations that we see. And so we see the nephrotic syndrome result in proteinuria and lipiduria, whereas in this condition, the nephritic syndrome, we find that hematuria is the hallmark characteristic, and also the urinary casts. And these urinary casts are sediments that are found in the urine that are formed just naturally. Okay, so these casts can increase in this nephritic syndrome. Okay. One other characteristic that we see in nephrotic syndrome is that the urine is likely going to be frothy because of the increased proteins, whereas in nephritic syndrome we're not going to have that frothy urine. Notice that we don't have proteins over here in the manifestation, so we don't have the proteinuria that we see in nephrotic syndrome. So you're going to expect hematuria, so this increased capillary permeability can result in blood in the urine, urinary casts, leukonuria, which is talking about leukocytes in the urine because it's talking about really an infection being the primary cause of this one, so leukocytes are going to be found in the urine. Now ultimately this results in damage to the glomerular capillaries and results in scarring tissue, and so now your glomerular filtration is going to decrease, and we end up generating azotemia because this glomerular filtration has decreased. Azotemia is increased blood urea and blood creatinine, and then oliguria, right? So if we get scar tissue forming on the glomerular capillaries, now we are forming less and less urine. So the hallmark characteristics here are leukonuria, hematuria, urinary casts, and oliguria, so the reduced production of urine. So back to glomerulonephritis as a whole, we would want to diagnose this as a whole characteristics, and so we'd be able to need to differentiate between glomerular nephrotic syndrome and nephritic syndrome using the manifestations that we see, collecting urinalysis and blood chemistry levels, so looking at the blood urea and creatinine levels. And then the urinalysis, we would be looking for protein in nephrotic syndrome, and then nephritic syndrome, we're going to be looking for red blood cells, white blood cells, maybe even some protein later on, but that is not going to be the hallmark definition of it. So we would want to be looking for that stuff in the urine. The blood chemistry, we're going to be looking for elevations in urea and creatinine, serum antibody levels to look at liver function, because the liver function is going to be altered because now we're going to be losing some of this stuff in the urine, like proteins and lipids. And in this case over here, so we see the increased erythrocyte sedimentation, which then we're going to result in an increased erythrocyte breakdown. Okay. To visualize these things, we would use a CT scan looking for any kind of renal swelling. And then we would want to collect a renal biopsy to collect a sample of the renal tissue to look for scar tissue damage. So for treatment of this, generally we see that this can kind of recover on its own. It's usually not a problem. However, age can factor in, and so the younger an individual is when they get it, they end up recovering from this quicker. We could use pharmacological approaches in addressing this, specifically antibiotics if the disorder is due to a bacterial infection. Okay? Corticosteroids to reduce chronic inflammation event like lupus or rheumatoid arthritis. Now, now remember that anytime we affect glomerular filtration, we're affecting blood volume, which has direct implications on blood pressure. And so if we are filtering less of our blood, we're increasing our blood volume, and we're increasing blood volume. So that increases blood pressure, and so blood pressure is a concern here. And so management of blood pressure also becomes a form of treatment, and specifically we would probably be wanting to look at ACE inhibitors, so angiotensin converting enzyme inhibitors. Maybe we would want to use a beta agonists, calcium channel blockers, or diuretics. And so we would want to increase the amount of urine production by using a diuretic, something like Lasix or something, which is a loop diuretic. Okay. Last but not least, if we have azotemia developing, we would want to undergo dialysis treatment to remove those nitrogenous wastes from circulation. So here we have nephrotic syndrome and nephritic syndrome, and you see the causes of nephrotic syndrome over here are caused by really these chronic inflammatory events. We end up resulting in glomerular capillary inflammation, and so first and foremost we increase the capillary permeability, and so this results in proteins escaping circulation. We see the basal membrane thickens, and so long term this really decreases glomerular filtration, and we can get the replacement of the glomerular basal membrane with scar tissue. Okay. Now these are going to be the hallmark symptoms, manifestations that we're looking for. So we're looking for proteinuria and lipiduria, and the proteinuria is due to the albumin escaping through the increased porosity of the glomerular capillaries. Lipiduria is going to be due to increased function of the liver producing lipids. Okay. So we would expect for loss of protein for edema to follow suit, because now the colloidal osmotic pressure is decreasing, and now reabsorption and capillary exchange is decreasing as well, resulting in a buildup of fluid inside the interstitial space. Okay. We see that the loss of fat is also a cause of concern here. The liver increases production of triglycerides and cholesterol production, partially due to the proteinuria. Okay. So nephritic syndrome, if we look on the right side here, nephritic syndrome is going to be an inflammatory response generated from antigen and antibody immune complexes. Remember, that is a type 3 hypersensitivity. So that is going to generate an inflammatory event based on these immune complexes presence, and this is going to be due to acute infections. So primarily the bacterial infections, so streptococcus or monoinfectious nucleosis. Okay. And so we have these immune complexes, they get embedded into the glomerular capillaries, we recruit a bunch of white blood cells there, we take care of the infection, it is gone. Okay. About 10 to 14 days later we develop this, and so the cells of the glomeruli increase in permeability, resulting in blood in the urine, so red blood cells in the urine. Hypertension results because anytime we have a reduction in GFR or protein in the urine, we withhold a little bit of fluid, and so this hypertension, edema, and proteinuria are all associated. And we would expect azotemia, which is an increase in blood urea and blood creatinine. And then remember, we see an increased red blood cell sedimentation. Okay. So the treatment of these is normally self-terminating, but if we need to, treat with antibiotics. So this is remember that in the treatment we also have pharmacological tools like corticosteroids that can reduce the chronic inflammation event. We also have pharmacological tools that can treat blood pressure and that we have dialysis treatment that can remove nitrogenous waste from circulation. So, with that said, that is the end of this lecture over glomerular nephritis, over nephrotic syndrome and nephritic syndrome.